So this course is about tackling cataract and glaucoma together, the twist and the turn. Many a times we get patients who have both the diseases, and we know both diseases have to be tackled together very nicely. Otherwise, we can land up in some complications. So in this session, we have cataract and trabeculectomy, refining the surgery by myself, Dr. Shalini Mohan. Then we have Dr. Colonel Madhubudaria Madam from Sitapur. She will be talking about glaucoma valve and cataract, when and how. And then we have Dr. Sushmita Kaushik from Chandigarh. She will be talking about the tough nut, congenital glaucoma and cataract. We have Dr. Shweta Tripathi from Indira Gandhi Lucknow, and she will be talking about the newer glaucoma surgery, MIGS and cataract, the options and feasibility. And then we have Dr. Devang Ongmu from RP Center AIMS, and she will be talking about the dilemma of PACG and cataract. And then we have one keynote address also from Jakarta. So I will be starting my own presentation on cataract and trabeculectomy. So we can have three scenarios where cataract surgery alone can be done in the patients where it is mild or moderate glaucoma with controlled intraocular pressure or anti-glaucoma medication. Then we can do and plan combined cataract and trabeculectomy surgery in patients who have advanced glaucoma and uncontrolled IOP on AGM. Or there can be a subset of patients where trabeculectomy was already done and they have usually significant cataract, and then we have to perform surgery. So I will be dealing these two problems in subsequent slides. There should be some special consideration whenever we are planning surgery in these subset of patients. Sometimes there can be poor pupillary dilatation, for which we might be needing sphincterotomies, or pupil stretch, for which we need to have Coughlin or Sinskey hooks with us. We might be needing mechanical dilatations, so in our basket iris hooks or rings should be there. Inadequate anterior chamber visualization might be an issue, so better to stain the capsule, and anesthesia can be your per own choice. So whenever we are combining cataract and glaucoma surgery, there are potential advantages because it is a single visit for the surgery and therefore convenient for the patient. It avoids post-operative IOP spikes, and long-term IOP control is good. But then there are potential disadvantages also, like there might be more intraoperative and post-operative complications. Now, sometimes cataract surgery becomes challenging in such patients due to vitreous loss, and more inflammation is introduced, and combined procedures may be less effective sometimes also. So this is the combined surgery done from the same side for cataract and trabeculectomy. So this is superior phaco being performed and rhexis is being done as you do. Now after completing your capsular rhexis, it is important to keep your bottle height less because we don't want these compromised eyes to be under high IOP. Now I'm making a fornix based conjunctival flap, do minimal amount of cauterization to these patients, and this is a partial thickness scleral flap being made by the crescent knife as you do for your small incision cataract surgery entry into AC, and then phacoemulsification is completed from the same entry which you have made through your scleral tunnel. So entry should be of 2.8 if you are using a phaco tip of 2.8 or 2.2 depending on your own phaco tip. This I have fast forwarded. After completing phacoemulsification, you do thorough cortical cleanup. Now here it is important that the phaco parameters should not be too high, otherwise iris might prolapse because there is floppy iris. Then you insert the IOL through the same port and same scleral tunnel which you had made, and after that don't forget to put pilocarpine eye drops because the pupil should be nicely constricted because we have to do iridectomy. So once you are complete with your phacoemulsification, then you see the tunnel. Now you can cut the sideways of this scleral partial thickness tunnel to make a partial thickness scleral flap for further trabeculectomy surgery. Now after this you need to identify the junction of white and blue where you have to enter the AC and you have to do punch also. So this is the sclerostomy punch which comes into 0.5 and 0.75 dia, and then you can punch a nice opening over there. Now, if you're not satisfied with the size of opening, you can punch it again so that you have nice circular opening. It should be a regular opening, and from there you need to complete your iridectomy so that it doesn't come and block the ostium. Now, after completing your this thing, you have to suture the scleral flap. You can put releasable or non-releasable sutures depending on your own requirement or whatever you have decided for the patients. And once the suture should be nicely buried, and then you have to close the conjunctiva. Now, closure of conjunctiva is very, very important. We put two wing-shaped sutures. Tight closure is important. It should be a watertight closure so that the bleb forms nicely in post-operative period. Sometimes you might need to put a corneal suture so that if bleb is leaking from the cornea, it might not. So this I am putting a suture in the cornea and tightly securing the bleb. So now sometimes the conjunctiva might be overriding on the surface of the cornea. This is burying of the knots onto the cornea. If conjunctiva is overriding after you suturing, better to trim it to avoid any overhanging bleb formation, and then you can complete your surgery and check that the bleb is forming nicely in the post-operative period. So once you are happy about the bleb, then you can close your surgery. So this was same site surgery, but sometimes we need to plan a different site surgery also. So this is temporal phacoemulsification for the patient, and I will be doing a superior trabeculectomy. So cataract surgery is almost the same, nothing much about it. But once you have completed your temporal phacoemulsification, then you need to shift superiorly to complete your trabeculectomy surgery. I am putting a corneal stay suture because the exposure was not very good. So you can put a corneal stay suture with a Vicryl 60 and then make a fornix-based conjunctival flap, do thorough cauterization. In this patient, the bleeding was slightly more, and then complete your trabeculectomy surgery superiorly, same as we did in the previous case. So this was a trial, a good study of one-site versus two-site phacotrabeculectomy, a randomized study, and they found that both techniques yield similar result, but two-site group has less induced astigmatism and a better post-operative IOP control with less required anti-glaucoma medication. So the two-site surgery is better in long-term IOP control and in long-term requirement for anti-glaucoma medication. So we generally go for two-site surgery. Now, another instance can be where trabeculectomy surgery is already there and cataract has formed, and now we have to plan cataract surgery. So, in this subset of patient, there is you can see a bleb in the superior area and cataract is there. So, you have to reduce your phacoparameters because iris is very floppy, reduce the bottle height, reduce the aspiration and flow rate because you don't want any iris to prolapse outside. So, once you have entered the AC, you complete your phacoemulsification with your low-end phacoparameters, and after that you can see iridectomy in the superior part also. Be in the central space because if you go too much in the periphery, you might catch the iris and can subsequently lead to iris atrophy or maybe in dialysis. So this is a routine phacoemulsification as is done. Now this is one interesting case where pupil was not dilating nicely, and this might happen many times after trabeculectomy surgery. Now we tried to stain the capsule, but it was the pupil was very, very small, and we tried to put high viscosity viscoelastic, but iris started prolapsing. So after repositing back the iris, what we planned to put two iris hook so that we can have a better visualization of anterior lens capsule, and iris hook placement, you can see after iris hook placement the visualization of anterior lens capsule was nice, and then the surgery could be completed. Now in such a case when iris is repeatedly prolapsing, then you have to be more careful regarding managing the iris. Now whenever I did hydrodissection, again iris started prolapsing. So after completing phacoemulsification, Under low parameters, it is not a bad idea to put one suture to secure your wound nicely so that you don't have any problem in the post-operative period. So this is the routine phacoemulsification being completed, and after that I have put one suture in this particular patient after implantation of IOL. Thoracortical cleanup is very, very important because these are already inflamed eye. We don't want inflammation to be more, and after removal of iris hook, this is IOL implantation, and then after IOL implantation, this is putting up a one suture. Now, in cases where you have poor pupillary dilatation, you can also plan to insert Malugin ring, or any other B-hex is also easily available with us. So you can put these rings, and they give very, very good visualization and comfortable area to work. And moreover, but you have to be very, very careful because iris is already compromised in such situation. So whenever you are removing these rings, you have to be very, very careful that the iris doesn't get entangled in the ring, otherwise it might lead to iridodialysis. So cataract surgery after trabeculectomy surgery increases the risk of trabeculectomy failure. So we have to be very, very careful. And if the duration between trabeculectomy surgery and cataract surgery is lesser or shorter, more are the chances of failure of trabeculectomy. And therefore, whenever you are planning, give substantial amount of time for between trabeculectomy and cataract surgery. So this is a small incision and trabeculectomy surgery, and here is small incision cataract surgery is being performed, and you can see I have taken this video from Dr. Sudhir because he routinely does SICS with trabeculectomy surgery. And after completing your SICS, then you can punch the sclera, the partial thickness ostium beneath the partial thickness flap, and this is after completion of your surgery, small incision cataract surgery. Then you can see that how this is the punch, and you can punch the ostium in the partial thickness scleral flap, and then complete your surgery by doing iridectomy. So that way you can combine your small, if you are a proficient small incision surgeon, you can also combine your surgery with trabeculectomy surgery, and then you must suture it nicely so that there is no leak in the post-operative period, and moreover you get good bleb formation. So this is completion of the surgery, trabeculectomy surgery, and then you can close the conjunctiva as we did for our phacotrabeculectomy. So in post-operative period, besides antibiotic and steroid, it is important to use cycloplegics also, because we should keep the iris mobile in the post-operative period. So to conclude, I would say that proper pre-operative planning, good intraoperative strategies, and adequate post-operative management is important for successful surgery. Phaco versus SICS depends on the surgeon's own preference. Only trabeculectomy if there is no cataract. In combined surgery, two site is more preferable. Thank you so much for your kind attention.